Hi everybody, welcome back to my next video, and today I'm going to be presenting the cornea's most common infectious disease, bacterial keratitis. So let me also tell you that with this video I'm starting a new album which I'm going to name Medical Cornea, and in this album I'm going to include all related topics. So make sure you stay tuned, subscribe to the channel to upcoming videos. And today we're starting with bacterial keratitis. Let's get started. Introduction. Here I would start with a general information of bacterial keratitis, which is a common and potentially sight-threatening corneal infection. Ocular trauma and contact lens use are the most common risk factors. When potential infection is suspected, laboratory investigation should be considered. The therapeutic plan can be initiated and modified according to the laboratory findings, clinical response, and tolerance of the antimicrobial agents. Antibiotic therapy is the mainstay of the treatment, and surgery may be considered if medical therapy fails or if the vision is markedly threatened by the infection or resultant scar. I would continue here with host defense and risk factors. Defense of the ocular surface starts with the eyelid. Bacterial keratitis usually occurs in patients with predisposing risk factors that compromise normal ocular surface defenses. And eyelid disorders such as blepharitis, dacryocystitis, ectropion, entropion, lack of thalamus with some kind of disorders lead to disturbed precorneal tear film that can predispose to bacterial keratitis. Tear film. Normal blinking distributes the tear film, which washes away potential pathogens via the nasolacrimal drainage system. Corneal epithelium. Just a few bacteria can pass through an intact epithelium. Those are Neisseria gonorrhoeae, Corynebacterium, diphtheria, Haemophilus aegyptus, and Listeria monocytogenes. Normal ocular flora and normal conjunctival flora helps also to prevent overgrowth of exogenous organisms. External risk factors. Corneal trauma, chronic topical anesthetic abuse, contaminated water, contamination of ophthalmic solutions, then contact lens use. The incidence of contact lens related infections is very high in AFACs, patients with a corneal transplants, patients wearing bandage contact lenses, poor hygiene of course, and smoking. In this case of bacillus keratitis, we can see in the center of the cornea the ring ulcer and stromal necrosis, and this is a case of which is associated with trauma and topical anesthetic abuse. A case of contact lens. So a contact lens causes hypoxia and changes epithelial hemostasis. So hypoxia will lead to endothelial dysfunction, and this will lead to epithelial edema. In case of slowing epithelial hemostasis, it will suppress proliferation, migration, and will reduce cell exfoliation. In case of Pseudomonas keratitis, for example, on the photo above, we can see a ring necrotic stromal infiltrate in Pseudomonas keratitis, which could also simulate acanthamoeba keratitis. And in this case, laboratory analysis would help to define which exactly infection we are dealing with. On the second photo, we can see paracentral corneal infiltrate with a surrounding corneal edema and also hypopyon. Ocular surface abnormalities can also lead to bacterial keratitis, and those are cicatricial pemphigoid, Stevens-Johnson syndrome, vitamin A deficiency, radiation and chemical injury, chronic epithelial defect in post-keratoplasty patients, for example, then post-corneal surgeries, and systemic conditions. And here on the photo we can see an infiltrate in the deep stroma around the suture tract of a corneal graft, and this condition developed after suture removal. Systemic conditions such as malnutrition, diabetes can also compromise the ocular surface and increase the risk of microbial keratitis. With such a rare infection such as Moraxella keratitis or Mycobacterium keratitis. In case of Moraxella keratitis, we can see a superficial corneal ulcer with moderate corneal edema and mild infiltrates, and this is a case of a diabetic patient. And on this photo we can see several intralamellar infiltrates with a feathery edge, and this is a case of inflammation after LASIK surgery. Pathogenesis. Pathogenesis starts with bacterial adherence, and in general, bacterial keratitis, as you already understood, can be caused by multiple microorganisms. Shortly after a corneal injury, bacteria adhere to the damaged edges of the corneal epithelial cells and to the basement membrane or the Bayer stroma near the wound edge. And the glycocalyx of injured epithelium is particularly susceptible to attachment by microorganisms. Then comes another step. This is bacterial invasion. Bacterial invasion begins within hours after exogenous contamination of a corneal wound or after the application of a heavily contaminated contact lens. And the combination of epithelial surface proteins with the cell surface proteins and integrins will provoke bacterial invasion into the stroma. And once bacteria is in the stroma, it will lead to release of protease by bacteria. In this condition, without antibiotics, bacteria continue to invade and replicate in the corneal stroma. Microorganisms in the anterior stroma produce proteolytic enzymes which will destroy stromal matrices and collagen fibrils. And viable bacteria tend to be found at the peripheral margins of the infiltrate or deep within a central ulcer crater. Corneal inflammation and tissue damage. So recruitment of acute inflammatory cells occur within a few hours, as I already said, after bacterial invasion. This will be followed with vascular dilation of the conjunctival and limbal blood vessels, and extensive stromal inflammation eventually will lead to proteolytic stromal degradation and liquefactive tissue necrosis. Clinical presentation. Common presenting symptoms are general symptoms and severe symptoms. So general symptoms, those are basically all symptoms of corneal syndrome, which includes pain, decreased vision, tearing, photophobia, eyelid edema, and conjunctival hyperemia and chemosis. And severe symptoms includes anterior chamber reaction and hypopyon. So this is a case of acute severe bacterial keratitis with a mucopurulent exudate and underlying stromal infiltrate, which is a hallmark sign of infection keratitis, and additionally multiple focal stromal infiltrates, which can be seen in contact lens user or a patient with a polymicrobial infection. And of course, we can also see that hypopyon is also exists. Clinical examination, of course, would include a detailed history, ocular symptoms, visual acuity, detailed slit lamp biomicroscopy. The cornea has to be documented in terms of epithelial defect, neovascularization, Dalen edema, and infiltrates can be also, the location can be defined. It can be central, paracentral, perineural, adjacent surgical, traumatic wound. The density, size, and shape can be also different. It can be a ring shape or satellite shape, and the depths can be also defined using, for example, corneal OCT examination. The infiltrate margin also can be suppurative, feathery, soft, or crystalline. The color of a corneal ulcer can be also different from white to very dark yellow, and of course anterior chamber reaction should be also defined if the patient has cell, flare, hypopyon, or fibrin. Signs of severe corneal ulcer includes rapid progression, infiltration dimension more than 6 millimeters. The depth of the cornea can be damaged more than 1/3 of the thickness, and the patient may also have a high tendency for perforation, and sclera can be also sometimes involved. So here are some clinical samples. In the first case, we can see a ring infiltrate with a stromal necrosis and central thinning, mimicking acanthamoeba keratitis. And of course, in those kind of cases, when we cannot define which exactly keratitis we are dealing with, laboratory examination would be helpful. The second photo of serratia keratitis has a small and dense localized infiltrate with a small satellite lesion, and a superficial Staphylococcus aureus keratitis has a large non-infectious immune ring. Here again, a case of Pseudomonas keratitis in a soft contact lens area, we can see an extensive tissue destruction and a layered hypopyon. And this is the same patient after the treatment, and the ulcer is totally resolved, and the treatment was performed with fortified antibiotics, and there is a corneal scarring developed. Specific bacterial ulcers. Corneal ulcers can be infectious and non-infectious. Infectious includes cells and debris on corneal surface. Corneal epithelium is absent over the area of active infection. Suppurative corneal inflammation can be a case chemosis and associated conjunctivitis. In case of non-infectious ulcer, there are no cells and no debris on corneal surface and no epithelium defect. Gram-positive organisms. So we start with staphylococcal ulcers. The ulcers has distinct borders and non-edematous surrounding stroma. And long-standing ulcer without proper treatment can also lead to abscess. And they are generally associated with mild to moderate anterior chamber reaction. And here is the case of a staphylococcal ulcer, and we can see here intrastromal abscess of a severe case. Pneumococcal ulcers. They generally occur following trauma to the cornea. They are particularly associated with the case of cystitis. This is a very rapidly progressive, can also lead to corneal penetration, and in most of the cases there are always anterior chamber reaction associated with hypopyon, and if there is no proper treatment, it can lead to melting, and it can happen pretty fast. So this is a case of pneumococcal ulcer. Another case of a gram-positive organism is the nocardia infection. It tends to produce an indolent ulcer after minor trauma, and trauma-related nocardia keratitis can have multifocal chalky white infiltrates in a rare configuration on the leading edge, and this is like a characteristic feature of nocardia keratitis, which can be also confused with a mycotic infection. Non-tuberculous mycobacteria keratitis. These organisms tend to cause a slowly progressive keratitis and usually occurs after corneal foreign body, corneal trauma, or following corneal surgery. And the diagnosis may be challenging in LASIK patients because infection can be confused for diffuse lamellar keratitis, and lack of response to conventional antibiotic therapy is usually a clue to the diagnosis of this unusual keratitis. And this is an image of non-tuberculous Mycobacterium keratitis with a central stromal infiltrate surrounding corneal edema and minimum associated inflammation. In this clinical sample, we can see Mycobacterium chelonis case of keratitis following a refractive keratotomy procedure, and resolved Mycobacterium infiltrate following antibiotic therapy from same patient. And the second figure, it's a Streptococcus pneumonia corneal ulcer in an immunocompromised patient with deep stromal infiltrates and dense hypopyon. Gram-negative organisms, Pseudomonas ulcers, for example, presents as a rapidly evolving infection and may lead to perforation and loose eye if left untreated. And it can be also slowly progressive and with an anterior chamber reaction from mild to moderate. A characteristic feature of Pseudomonas ulcer is the diffuse epithelial graying, which characteristically occurs away from the main site of epithelial and stromal infiltration. And of course, the progressive untreated ulcer is also associated with melting of the cornea. Other gram-negative rods, such as Moraxella ulcers, typically indolent with only mild to moderate anterior chamber reaction, and it's usually oval and located in the inferior part of the cornea. And anaerobic infection usually follow corneal injuries with a contaminated soil. And some ulcers may have prolonged, moderately severe stromal and anterior chamber reaction with endothelial decompensation despite proper treatment. Laboratory investigation includes corneal scraping, and there are also some indications for that. Those when the corneal infiltrate is chronic, central, large, deep, or atypical in appearance, And in this case also aqueous or vitreous taps should not be performed in order to decrease the possibility of intraocular microorganisms invasion unless there is a high suspicion for microbial endophthalmitis. Only in that case you can perform aqueous or vitreous taps for laboratory analysis. There are also some indications for reculture in case of lack of a favorable clinical response or toxicity from medications, or corticosteroid withdrawal may be also confused with antibiotic failure. Therapy. As I already said from the beginning of this presentation, the mainstay of the therapy for bacterial keratitis are antibiotics. So let's start with cephalosporins. Those are cefazolin and ceftazidime. Cefazolin, this is the first generation of cephalosporins and has an excellent activity against gram-positive pathogens and minimal toxicity. And mostly cefazolin can be combined with other agents against gram-negative bacteria in order to provide a broad spectrum of coverage. The next one is ceftazidime. This is the third generation of cephalosporins with anti-pseudomonas activity and also can be used in combination with aminoglycosides or fluoroquinolones. The next antibiotic is glycopeptides, vancomycin, which is mostly being used for systemical approach with intravenous injections, for example. And vancomycin inhibits the biosynthesis of peptidoglycan polymers during bacterial cell wall formation, and it's primarily active against gram-positive bacteria and remains one of the most potent antibiotics against MRSA and coagulase-negative staphylococci. The next one is aminoglycosides. Those are gentamicin and tobramycin. Those antibiotics have a bacterial effect against aerobic and facultative gram-negative bacteria, and this kind of antibiotics also can be used in combination with anti-pseudomonas cephalosporin. Microlids antibiotics, they inhibit bacterial protein synthesis, has an activity against gram-positive and gram-negative bacteria, but because of their pure solubility and limited corneal penetration, topical preparation of these newer microlids may have a limited role for bacterial keratitis. The next type, and my favorite type of antibiotics, those are fluoroquinolones, ciprofloxacin, ofloxacin, and levofloxacin. Those are second and third generation, and gatifloxacin and moxifloxacin. This is the fourth generation. So second and third generation has an activity against gram-negative and some gram-positive bacteria, but no effect to pseudomonas, for example. But the fourth generation, first of all, has a better coverage of gram-positive pathogens than early generation fluoroquinolones, and has also activity against pseudomonas infections. So that's why I personally, and in general in our clinic, once we use fourth generation fluoroquinolones, we don't combine additionally some topical antibiotics from cephalosporins or aminoglycosides because of the broad spectrum of coverage. Strategies for initial management. Here I would talk with a few steps which you have to start with before you start your therapy. So first step, start with topical antibiotic drops. In general, I think that topical antibiotic eye drops, they achieve high levels of tissue concentration. Ointments may be useful therapy overnight in less severe cases, but may impair the penetration of topical eye drops. So here we start with a single drug therapy or combination therapy. So for single drug therapy, you may use broad spectrum fluoroquinolone fourth generation, or combination therapy fluoroquinolone, for example, second generation with cephalosporin antibiotics. And combination therapy is just up to you. You can use different type of antibiotics. The main purpose is just to get the broad spectrum of coverage. So you can use also systemic antibiotic in case of severe cases. And for central or severe keratitis, a loading dose would be started with 5 to 15 minutes for the first hour, followed by hourly applications. You can also use cycloplegic agents in order to reduce the pain which is associated with ciliary spasm and decrease synechia formation. And of course, never start with corticosteroids in case of corneal ulcer. The second step, choose your therapy approach. So there are three types of therapy approaches. culture-guided approach, when you just wait your laboratory analysis after performing corneal scraping. And disadvantage of this therapy approach is that it costs and time, of course. An advantage is just beneficial to monitor infectious trend. The second time is empirical approach based on pre-existing data. You just start with broad spectrum antibiotics, and advantage, of course, it's a convenience and cost effective. And the third therapy approach is the case-based approach, when you just do microbiological testing only for cases with ulcers involving the visual axis or deep large ulcers. The third step of your strategy, modification of therapy. There are some factors for therapy modification. So those factors are include positive response and negative response. So positive response, when you have a pain reduction, discharge reduction, less eyelid edema, less conjunctival injection. So a clear clinical improvement after your therapy. And the negative response, when there is a lack of improvement, no signs of stabilization after 48 hours, and progression after 48 hours. This is very important. So based on positive or negative response, you can modify your therapy. And in case when you have a negative response, then you have to stop your antibiotics for at least 12 to 24 hours prior to corneal scraping, and then you just re-evaluate and send again the new corneal scraping for laboratory analysis. So fourth step is corticosteroid therapy. The effectiveness of steroids for bacterial keratitis remains unclear. The objective in topical corticosteroid therapy is to use the minimum amount of steroid required to achieve control of inflammation. There are, of course, potential advantages and potential disadvantages of corticosteroid therapy. The potential advantages is that it suppresses the inflammation and reduces the corneal scarring. And disadvantage is activation of infection, local suppression of host defense, inhibition of collagen synthesis, which can lead to corneal melting. The successful treatment requires optimal timing, careful dose regulation, and use of adequate concomitant antibacterial medication, which means that once you start your corticosteroid therapy, please still continue your antibiotic therapy. You can reduce the dosage for a day. You can use like 2 or 3 times in a day antibiotics, but just never stop antibiotics once you start your corticosteroid therapy. And of course, the modification of your therapy, which will lead you to start with corticosteroids, is very important. So you have to really have some positive factors for modifying your therapy, and close follow-up, of course. Once you start your corticosteroid therapy, make sure that you have a close follow-up in order to see the dynamic of the disease. Therapy for complicated cases. So therapeutic soft contact lenses can be used in order to facilitate epithelial healing and prevent corneal perforation. And amniotic membrane, those are derived from the inner layer of the human placenta, and it exists in cryopreserved or dry forms. So amniotic membrane can be placed onto the ocular surface, and the therapeutic bandage contact lens may be placed on top of the amniotic membrane to maintain adhesion. And amniotic membrane is thought to provide a metabolic and mechanical support in non-healing epithelial defects after resolution of infection. And of course, it should not be placed over active infiltrate, as this may promote bacterial growth. Surgical management. Conjunctival flap as well as amniotic membrane provides tectonic support and vascularization to the infected area and promotes healing. It should not be placed over a necrotic area with active infection, because the flap can also become infected and necrotic. Particularly, this method is very useful in cases of non-healing peripheral ulcers where the flap can be placed without compromising vision. Keratoplasty. There are some indications and risk factors for this method. Indications are uncontrolled progression of the infiltrates, limbal involvement with impending scleritis, and corneal perforation. Risk factors are older age, delay in referral, injudicious steroid treatment, past ocular surgery, large or central ulcers. Please remember that therapeutic penetrating or lamellar keratoplasty performed for acute microbial keratitis can be difficult and is associated with higher complication rates and lower graft survivals compared to keratoplasty after ulcer resolution. Collagen cross-linking. I never personally had the case where I had to use this method, but there are a lot of publications proving the effectiveness of this therapy. Cross-linking forms chemical bonds between adjacent fibrils, thereby providing mechanical strength. The cornea becomes relatively resistant to enzymatic digestion by a variety of collagenases, and it reduces cornea susceptibility to proteolytic enzymes and corneal melt. All of these effects justify its use in the management of corneal ulcer. And this was all for today. Thank you for watching. Till the next videos, stay positive, stay healthy. Bye.